Hi, Frank. I feel like I'm one of the MNLEND faculty members. I always feel very guilty. I usually just show up once a year at this thing. So this is year 2. I've got a variant on what I'm going to do. So let me do the quick corrections. I don't know what it means to say I'm an educational psychologist, because then I get lumped in. My wife's a clinical psychologist. I don't know if you get who's psychology out there. You know, there's school psychologists, there's counseling psychologists, clinical psychologists. Educational, I'm in educational psychology, the department, which this is the building Ed Psych's in. Some of you may know this. There's multiple programs in Ed Psych. I'm in the special ed program as a faculty. And then in our college, which is the College of Ed and Human Development, we don't do vice dean. I'm an associate dean for research and policy. And what that means is I live in the world of middle management. So poop flows both ways when you're in the middle, from the dean down and from department chairs up, and I live in that little space. Actually, that's my little opener. See if I can figure this out. I'm not a Luddite, but I have properties like being a Luddite of not being able to make tech work. So I thought of this last night, that 0.5 and 0.5 don't equal 1. Some of you may live like this. So technically, the administrative role I'm in is a 0.5 appointment, and then 0.5 is my regular academic role. And so I disappoint people on a weekly basis because I'm falling short on. It's probably should be really like 0.7 plus 0.7. Can we do that? Can we make this all about me for the next hour? I don't get out much. I'm happy to be here. So, and I thought, do you guys all know Adele? Adele Dimian, does that ring any bells? Is she tied in with this? Okay, well, so I like earlier this week, it was like, oh yeah, I'm supposed to be doing this. What am I supposed to be doing? So I sent her a note. I think I have a LEND talk coming up. What was I supposed to talk about again? And she said, maybe your pain work. And I emailed Andy late last week. Well, I have this LEND talk. What am I supposed to talk about? Oh, right, our self-injury work. And he mentioned RET. So what I took away from it is just talk about what I want to talk about. So, ride the wave with me here. What I want to talk about, or at least what I think I want to talk about, is a metaphor that I know of, the lock and key metaphor, for how drugs and molecules work in the body with respect to conversations between neurons. And in that sense, there's receptors and there's molecules. And in this case, molecule A gets to talk to the receptor, molecule B doesn't. They bind, it's like a lock and key. That's the metaphor I have in my head. And in the context of pain, the action to understand pain, because it turns out not all pain is the same. There are different kinds of pain, and there are molecular signatures that are markers for, if you will, the kind of pain. So physiologic pain, cold, heat, mechanical, etc. There are different receptors. I don't know if I moved the cursor, if there's any, no, and I don't have a little pointer. But there are different receptor molecules at the synapse in our friends, the neurons, for how that pain is transduced. There's inflammatory pain. Again, a different set of molecular markers and receptors. There's one that's the NAV, the sodium channels. I'm going to come back to that. Finally, neuropathic pain. So pain of origin of central peripheral nervous system damage. It's complicated. There's lots of molecules, lots of receptors. So I want to talk today about the voltage gate and sodium channels. And if you remember from biology or your neuroscience, there's a lipid bilayer that forms the cell membrane, and embedded in that are protein molecules, some of which function as receptors. And then remember, there are multiple protein subunits that make up the channel. That's the receptor. And in the middle, there's a pore. And that's where the action is. So I wanted to talk a little bit today about how to think about when that pore is open and closed. Okay? Just relax. Take a deep breath. I'm not going to do that. Most of what I just said, I don't know what I just said. I was rehearsing this into the wee hours last night watching The Wild. I don't know why it occurred to me to think of, I'm going to mess around a little bit and do stuff I don't understand. So, but let me just make a quick confession, because I'm not kidding. My depth of knowledge on the neurobiology, neuroscience of thinking about what I just said, of how pain works, because I'm interested in pain and individuals with severe disability, in both assessment when it's complicated because of associated impairments with language or communication, motor, intellectual. But I hang around with neuroscience people, and that's the world they live in. So I live in that metaphor of the lock and key, and then these guys, you go hang out with them, and they show you this. I'm like, I don't know what those little ribbons are. So my strategy in part over the years, there's a pain journal club that's the weekly meeting of, there's lots of basic pain labs at the U, and they meet. And so I go kind of like in an osmotic way. I just try to soak it up like a sponge, and I usually, at some point, I do a little happy face, frowny face. I hit the frowny face point where I can't absorb anything more, and then I just sit in the back and drink my tea. I don't know, maybe I'm sharing my pain, no pun intended, I don't know what that means. So just kidding, I'm kidding. So here's what I'm gonna do. I thought I'll try to blend two parts of what I spend my time trying to think about in that 1.5 side of me, pain and self-injury, in really across the lifespan. We have projects that are focused right now preschool, birth through 5, but we have a history of working adolescents and adults. And there's kind of two broad flavors in our self-injury work. Applied, so assessment and intervention in whatever context that the individual happens to be in. And then more basic, not basic like that, but with more basic oriented questions that are developmental of, if somebody's gonna self-injure, how does that start? What are the risk factors? How does that get put in place? If we could understand that, could we do something to reduce the risk and reduce the burden? So those are the two flavors. And I started with self-injury, and then kind of my grandma question was, from my mom, was why would somebody do that, meaning hitting their head or biting their hand or whatever, and we're gonna see some of this in a moment. Doesn't that hurt? Which was a very straightforward, reasonable, simple question that turns out is hard to answer, because finding out if something hurts, again, in individuals where the gold standard for pain is still self-report. So it doesn't matter, there's a lot of sophisticated work like that, biomedical, basic neurobiological, molecular biology, really, and molecular genetics. There's also very sophisticated imaging-based work. So for any of us, maybe we volunteer, you go in a magnet, they do things, they image your brain in relation to what's going on in the brain with regard to pain. But still, with all of that, at the end of the day, they still are going to rely on whether you say, that hurts. I feel that now, in terms of whatever the stimulus is. So if you can't say that reliably, for whatever reason, then it's hard to figure out how to get access to that subjective experience, because pain's a complicated construct and subjective experience ultimately, right? So why would someone self-injure? Doesn't it hurt? I don't know the answer to that, and I've spent, I don't know, the last 10, 15 years trying to figure out how to figure out the answer to that, because presumably maybe the idea would be that if there was a pain component in a variety of different ways, different ways, pain's absent, pain is present, there's too much pain, and any one of those are different bins that people might live in, where if self-injury is related to that, might mean there's a different way to think about assessing and ultimately treating or intervening in a way that we don't right now. So those are those two things related for me. So what I thought I would do is I pulled a clip. In the old days, we worked hard to get video, and then we would get permissions and to show for purposes like this and all that. Nowadays, I just found on the internet a clip of a parent that posted a clip of her son who has problems with significant self-injury. So I thought what we would do, because I'm already into this of talking a lot, and make this interactive, is I'd show that clip. I think it runs 7 minutes. So we'll watch the clip, and then I just have a series of questions. And you guys are already organized by table, so I'll just make each table a work group. And we'll have question, we'll give a few minutes to answer the question, then we'll share how we thought about the question, and we'll go to our next one. So right off, within your group, which I'm calling your tables groups, if you could talk with this mother, and you have some role with regard to, let's say, that school, or you're coming from a healthcare environment, or a community advocate, whatever it may be, What questions would you ask, and importantly, why? All right, so take a few minutes, talk amongst yourself, have someone who's ready to report out, because I don't know anybody, but I can see you have name tags, so I'll get to use those to call on folks. So what would you want to ask that mom, and why? Go. So, and I didn't say right when I put the questions up, there's no right answer here. I didn't come in of, here's the answer, you guys just talked all about, and then here's the right answer. There is nothing beyond just a set of questions and the why. So but there's a few things I want to react to just to provide some context. So often if I'm doing like a talk, and I spend time making a distinction that exists, but maybe doesn't need to exist. So the distinction I make is I talk about who, if you will, I'll be the scientist, who I study, or the problem I study, self-injury, and the people that we study, that we include in our studies, are individuals with intellectual and developmental disabilities. Mild, moderate, severe, whatever terms you want to use, or categorical or diagnostic terms. Sometimes they have Rett syndrome, sometimes they're on the autism spectrum, sometimes they're not. But individuals in a general sense that are living with some form of intellectual and developmental disability. And the term used in there for what we were talking about, this YouTube video is talking about, and you saw some contusions behind the ears, self-injurious behavior. So what Kimberly just brought in is another world, and I'm saying another world because the two worlds clinically and scientifically tend not to talk. So there's a bigger world of individuals who are not living somewhere on the IDD spectrum, if you will, necessarily, with other forms or typologies of mental health issues that engage in something that some people call self-injury. Historically, it was referred to as self-mutilation. Most recently, it's referred to as, I'll give an acronym, you probably know it, so hold. Anybody ever heard of NSSI? So non-suicidal self-injury. That's the dominant term in the clinical research community for cutting and burning and all of that. So now so another dimension, very important that Kimberly raised, is forms or topographies, what it looks like. So presumably what produced that ear and behind the ear is he's striking his ear. He may be banging against that table, but my sense is he's probably hitting it. So there's a variety of forms or topographies. And depending on how you think theoretically about why someone does this, sometimes it's relevant to think about the forms or topographies, but for many, they don't spend too much time thinking about that. We can talk about that part later. But again, just reacting to Kimberly is it Kimberly or Kim or what do you, doesn't matter. I'm Frank or Frank, either way. Fred. The world of non-suicidal self-injury is bigger in terms of numbers and prevalence, and the forms or topographies look different. The patterns also can tend to look different in that often in the IDD world of self-injury, you have kind of two common, I'm not going to say variants in any definitive way of types, but broad patterns where they're frequent in the sense of daily, could be hourly, every minute kind of thing, or more episodic. And Kimberly alluded to that on her first part was you'd want to get a log, and they're doing some kind of log, but a journal or log to look for patterns. And then broadly breaking down this young man's world into good days and bad days and what's different about him, and is there clues in there to the pattern of self-injury, right? So, but head banging, head hitting, etc. In the larger NSSI world, and that head banging is daily, for no apparent reason, from the mom's perspective, daily, hourly, etc. Often, but not always, but often in the NSSI, the topographies are different. Let's say cutting and burning, piercing, and then obviously, we're getting into a continuum, right? That you get into culture and practice of, well, what do we really mean when we talk about self-mutilation as a disorder, as a diagnostic category? Because there are different cultures and communities in which there is all sorts of things done to one's body that are sanctioned or expected or required, rites of passage, et cetera. So there's a continuum for sure. On the one end of it that's considered quote unquote pathological, at least from a Western perspective, the topographies look different than what I'm talking about or what we study. So the cutting and burning and the frequency tends to be very different. It isn't usually the case. Now there's always exceptions, but it isn't usually the case that this is hourly, daily, right? There's long periods of times, so it's more episodic. But the intensity can be severe in a way that's very different from some folks are habitual skin pickers. They use the term habitual. That could be loaded or not, depending if you think about it. In some syndromes like Prader-Willi, they skin pick a lot. It's low intensity, but the frequency of it is such that it produces severe skin trauma. But that's different than months without an act and then an act that's extremely intense that results in cutting, etc., or skin break and all that. So to come back, because I want to give a few other folks an opportunity to comment on what would you ask the mom and why. An important distinction is these two worlds. And it's important just in the sense of to be clear in terms of who we're talking about. There's very different literature. So, but then I also made the editorial comment, I don't see a reason though, scientifically at least, why the two worlds don't talk. We have our own professional communities, we have our own scientific conferences. It is extremely rare that the two worlds ever talk to think about, well, maybe because you also had a piece of this. So what does anxiety look like in someone, to be very blunt, with an IQ of less than 50 who's nonverbal? If we think anxiety is part of the driver, at least some self-mutilation and NSSI, and we're on a human continuum, well, if anxiety manifests itself differently in someone who can't tell you they're anxious, maybe that's what that is. That's a fair presupposition, it's a fair theoretical stance, it's a fair hypothesis. But again, we don't ever talk to one another. And I'm an importer, I'm rarely an exporter. I like talking to other disciplines and groups to try to bring in, well, how do you approach the problem? Maybe we could take a run at it and modify it so it could work in this sample too. So if you get interested in it, it would be interesting, seems a little trite, important, fascinating, and potentially, an incremental step to try to figure out how could those two worlds and the science and the way that the problem is studied and understood not live on parallel tracks. Okay, thank you. Other thoughts on if you could sit down with that mom, what would you ask her? I'll go back right here, my back right. What did you guys come up with?
We were curious if there had been a recent change in her child's behavior. We were also curious what had worked in the past.
Okay.
We talked about communication as well. Did it say he was? I didn't know if he was nonverbal. We were curious if he is.
I know the exact amount you all know, okay. But it wouldn't be unfair to say probably nonverbal. So a very fair entry question is what kind of communication system that's functional exists? Yeah. And has anybody looked at back to patterns? How does that relate to when good days, bad days at a global level or more particular communication issues and episodes of self-injury?
We also said that mom seemed to be concerned about at school that rapid change where he quickly went to self-injury from an hour before there was nothing and all of a sudden there was serious self-injury. So we were curious if that's ever happened at home and what that looks like. Curious if he's ever had genetic testing before, what other support he receives at home. Are there siblings? Is mom a single parent? Are there, what does the household look like? So
those are good ones. Let me just pick on one or pick up on one, and anybody can jump in and comment. So I'll use my language for the home school. So context can matter. Then that's a great starting point right there of does what school report on and see, do you see the same thing at home? Because it can be back to clues. Again, I'll just keep going back to Kimberly and patterns. Patterns can tell us a lot. And this is a statement based on our research approach towards thinking about assessment intervention. The more you understand the pattern and what's related environmentally or quote unquote biologically, whether it's proximal stuff, immediate health issues, they're constipated, or more distal of general nutrition or health. But so I'll put all that in context. The more you understand that and can then think about pattern, I think that's what from an intervention point of view, that's going to give us some things to anchor on and come up with a plan. So context matters, and that home school is, essential to know. Do you basically see the same thing? Now, because what if you didn't? Right? What if what she's got, that log is from the nurse. Interesting, right? They refer to him as a patient, but that's another, you can talk about that later, at school. What if at home it was that he was rarely self-injurious? What does that tell you? Environmental and safety. He's comfortable, right?
Or something's hurting him at school.
Could be, yeah, there could be something going on at school that way. There's something else. Yeah. There's different kinds of interaction, different kind of. Oh, sorry, back in the back. I was trying to ignore the expert row.
They're just
Sorry, I'll be
Yeah.
quick. Well, kind of to your point, Frank, when I was in school psychology, we did FBAs, it was just as important to when do you see the child doing well, when do you see the person doing well, what does that tell you? There's data in that as well, just like what you're saying.
Yeah.
Right away goes to when they have problems,
Yeah.
which is important too.
No, right. We try to think of the patterns, but and it's, if you want, well, what's the pain part of this talk? I don't really have one. I'm going to end with one piece of functional stuff out of nothing of just to let people know around the pain piece and severe disability. But in the pain work we do too, particularly on assessment and the scales that we have either helped develop or used, it's the same kind of logic or the mindset of, tell me what a good day looks like that you think is pain-free, and when their bad day is. What does that, first of all, look like, the phenomena itself, and then we'll start trying to measure. I'm coming at this from science, so the next step for us is get it labeled, not in a diagnostic sense, but you tell us what you look for, and then we'll start looking for it too, and then we're going to measure it and try to get a sense of what's going on in good days and bad days, and bring in an asset perspective of what strengths, skill sets, et cetera, does individual bringing that seem to be on the good days working for them, and what those are those dropped out on the bad days, and how do we switch that calculus essentially? All right, I am mindful of time. That's one question, and I know everybody around the tables, we've got more to say just on if you could talk to the mom. Let's go to one more question. If you could go in now, directly observe, you pick the context, multiple contexts, just take a moment. What would you look for, always, and why? When would you observe, and how often? Okay, try that on. Okay, you guys. So if you could directly observe, what would you look for, and what? I mean, there's three parts. Pick off anything. What would you look for and why? When would you observe, and why, and how often? So you want to get a look at this. Tell us a little bit about what you were talking about.
I'd like to see a typical day and try to determine the function of the behavior. What is he asking for? Is it signaling that he's hungry? Is it signaling that he has to go to the bathroom? Or is it more just self-stim behavior? Or like, I don't know, I would observe at school and at home. Maybe at home mom's giving him what he needs before he even asks for it, so he engages the behavior less. Or at school, there's longer delays for what he needs, so I would see, is that the case when he's hungry or something, is he engaging in more behavior? Or is he getting that, and what is he trying to say?
So what would you specifically look for? I don't disagree with any of that. Those are good things. That's back to what's happening in the day. Days that we could characterize as good, maybe, or maybe bad. I heard, I'll use the word pattern, so it could be that there's communication attempts and how are those responded to. It could be that in one context like school there's more demands, or there's needs aren't being met, et cetera. But what specifically would you observe? What would you say, I need to see the following, I'm looking for the following things to count or measure or sample?
I think that maybe the number of times the behaviors are happening throughout the day, like the length of each of those activities, if they're in different locations, or like taking these different forms of the where he's hit his head against something, he's kicking something or whatever. And then how those are being addressed to when those are occurring or before those are occurring. Then is observing mom to see if she's doing something to prevent, and then observing what she does after those start occurring, and the same thing with at school.
Okay, all right. And did you have your hand up? Just nailed it? All right, perfect. Good synergy there. All right. Yeah, so what did we just hear there? Back to pattern that Kimberly launched us on, more specific from the first round of conversations of specific forms, and then also in there, what's happening before and after in terms of, again, patterning related to, is there anything that sort of hangs together maybe over time? So, and you made a point of making distinctions about different topographies, that you might not lump everything as one thing. Why would you do that?
It might be indicating different things, like if he's hitting behind like his head, is it a headache, is it an ear infection, is it something that's like affecting the neck region, or is it he's picking on his arm because that hurts, he's hitting something because he's frustrated with it, or like hitting his head against something if he's frustrated with that.
Okay, so I'm gonna pivot us just a little bit because we're gonna run out of time. I had a few more questions. I had no goal. Well, I had no goal. I had a goal to get here reasonably on time and start this conversation. I didn't anticipate finishing it. So let me just pivot, because I've heard that 3 different ways. So there's some health issues maybe we'd want to know about, right? So I heard headache, and then earlier we talked of could be anxiety, he could be anxious, could have a headache. Just staying with what we know of this young man. He could have a headache, he could be anxious, right? And those may be plausible reasons why he's having some difficulties. How would we find out if he has a headache or he's anxious? What it's looked like in the past. How would we know? He can't tell you, I have a headache, I'm anxious. So how would we say, besides I think he's anxious, I think he has a headache, what would we do to find out? Is it Aaron?
Yes, so I think what you're trying to get at is like when you're observing him, looking for nonverbals. So is there a movement that he does? Is he more still, or does he shimmy around, or any sort of nonverbal cues?
That's good. No, well, just to be very clear, I'm not doing any leading questions of I have something I'm trying to get to, but you're hitting a good spot for me of, yeah, we're interested in nonverbal behavior. So that's not irrelevant, right? Of thinking about, so I'll insert the word pain. Let's go with headache. We'll get to anxiety in a minute. So pain. If we think he's got a headache, and we think it's not unreasonable to think that headaches cause pain, we might look for some sign, because what's the difference between a sign and a symptom? And signs are, and symptoms of subjective rely on what? Me being able to tell the doctor something's bugging me. He can't do that in a conventional way. So we're going to flip the signs. Yes, ma'am.
Well, I was just going to say try.
I was kind of rolling there.
Although he's
And then
not
no, I'm just messing.
trying to find like a alternative communication method.
Yes,
Or
yes.
he already has one in place.
Yes, and we do, and that got brought up. Communication's a big deal, right? I mean, for a punchline, for a starting place for me with a young man like that, if there's no formal means of functional communication, even if I didn't know anything else about him and anything about self-injury or problem behavior in general, but there's no functional means of communication, you're going to want to build that because it matters. It matters in how he controls his day and how he gets to navigate and regulate what happens to him in that exchange that makes all of us human. It needs to be in there. And we don't know anything about whether it is or isn't. And it turns out it's not irrelevant in a very detailed and distinct way with regard to things like self-injury, that those things tend to be related. Not always, but often in individuals for whom communication is impaired for whatever reason, you tend to see behavioral issues, right? So that's an anchor point of communication is something to put something in that we can build around. So let's go back to health though, in general. nonverbal signs and symptoms. So if there's a suspicion of index that he's unhealthy generally or there's something specific, but he can't tell us, so we're going to rule out symptoms. How do we figure that out?
I was thinking about like a baby, maybe they don't talk.
Yes.
But if baby is sick, they may try, the physician may try treatment and figure out if that what that means was that problem.
Yes, yes, exactly. So I think of that as proof by analgesia, right? Because you've hit it though. There are other populations, back to kind of my setup of what I'm interested in, there are other populations that are either pre-verbal or non-verbal for different reasons. Pre-verbal in terms of newborns and neonates. And just as a quick textbook aside editorial, for a long time in the West, can't speak to the rest of the world, in the West, the dominant belief in neonatology was that infants didn't feel pain. This is just typical development. Don't feel pain, the wiring's not in place. And so procedures were done that were highly invasive. You know, thoracic stuff, going in for fixing a valve, etc., that were done with no analgesia and no anesthetic. They would just be done with paralytics. This practice is up through the 70s and 80s. So there was a lot of science and a lot of politics, particularly from one particular mom, who drove a big change in the way the West conceived of whether newborns feel pain and maybe drop analgesia in for procedures, because it sets up problems. So it became if it looks like a duck and quacks like a duck, it's probably a duck. The default, it seems, in much of our practice, medicine and otherwise, is you assume it's not there, because there's sort of, if you can't measure it, you can't manage it, and it doesn't exist. So that's in typical developing populations, pediatrics, et cetera. That's a recent history. So when I talk to certain groups about what we're trying to figure out, the nonverbal measurement of signs of what would be consistent with what we think are pain expressive signs in populations with severe communicative impairment associated with IDD in general. People who spend time in the clinical research community, it resonates, and often they will say, this feels like where we were 30 years ago. And it is true. The way that pain is thought about in severe intellectual and developmental disabilities, unfortunately, is as if we're 30 years ago and then everything before. It's either been historically denied or discounted in one of two ways. Either the belief is that, quote unquote, they have an intellectual disability, they don't feel pain, so they're not sensitive, or they don't care about it. So maybe there's sensitivity, but it doesn't bother them. In either variant, the outcome from a healthcare perspective in general, and with relevance to self-injury, is pain is rarely thought of in the index of suspicion in relation to this behavioral phenomena, and so it isn't investigated. And so the logical way, though, proof by analgesia, is drop something in and see if it's a headache, how would you treat a headache? Treat the headache and see if, quote unquote, the symptoms, we'll stay with the medical language, go down. And is there any pattern there? And it becomes a little N of one case study that could be done. That's logical. It's very rarely followed systematically. So a lot of my time is spent in these early conversations with parents and other providers of trying to figure out how they think about the problem, and not so much even about the self-injury, their beliefs about that child or that patient of what their capacity is. And then it's my little entry of, well, have you ever thought about? And then trying to get them to decide that's something we could test, rather than saying it's that, so that's pain, headache in particular. And so that's the way, one of the first things I do when we meet with people is find out when the last full physical. When's the last time you've made sure that things go in, things come out, right? It's working well, the ears are clean, there's no blah, blah, blah. Just make sure the individual's healthy. So let's talk about anxiety though. And then I got to stop because it's like 11:30. You guys have been here since, I don't know, 8 and made to sit for an abnormally long time. Yes, I have no doubt. Well, I saw the board and I came in quite intimidated. After I saw the board, I was like, I could still turn around and walk out and say, wrong room. So, but just, and then I'm going to show you one more slide that has a website for those of you who are interested in, well, what is happening in pain assessment tools for severe ID, and then I'll stop. But so if hypothesis is health in general, something particular like a headache, toothache, earache that is acute pain at least, you could do proof by analgesia. Why not drop a painkiller in and see if the self-injury stops? And there's other indicators of he's good, he seems happy, you know. What about the anxiety piece? Again, we're back to subjective, just like pain's subjective. Needs self-report, no self-report. So what's our suspicion of index to say that's anxiety? How would we figure that out? Stress management, you're
Same thing, you treat it and see if it behavior.
all right, you guys are good. Yeah, it's the same, it'd be the same thing, right? You don't have to shy away from it because it's more of a psychological construct. If there's, I mean, my general go-to is what exists in the general population must exist in this population, and in fact, they're vulnerable, and so maybe there's even more of it, and we're overlooking it. So if there's something that works, quote unquote, for anxiety, then go to trial mode. Have a good measure and go to trial mode and try it and be an empiricist. And I mean, we're already collecting data of a certain kind, detailed logs, so that's good. So let's try something and try one thing at a time and see what it does. But you have to have a commitment that we understand what a good day and a bad day looks like and all of that stuff. All right. Anybody, whilst I transition to transition, any general specific comments on thinking about this? Yes.
I have a question.
Yes.
Has there ever been studies done about some way of figuring out if, like, these individuals with intellectual disabilities are feeling the pain when they're doing this at the time?
So, no, yeah. Well, everything goes back to Kimberly. So Kimberly talked about her daughter, if I may, your daughter saying she didn't feel pain, but she felt release.
Right.
So there is a literature in the NSSI world on pain and acts of cutting and burning, etc., where that, I don't know if it helps or matters, but I mean that maps on. So there's bodies of work where turns out there are very distinct subgroups, if you will, where some experience pain, some don't. Some experience relief or euphoria, some don't. Now, so back to biology, it's like, well, is the wiring a little different in each case that relates to a slightly different mechanism that's where you target treatment, right? So again, back to what I just said. So if that's relevant in this much bigger population that has this problem, that kind of thinking, how would we figure that out? I don't know if we ever caught, I'm blocking on, what was the young man's name? Jamie. Would that be relevant for Jamie of knowing, back to what I said, my grandma's question from my mom, does it hurt? So we're taking a run at that, of trying to figure out what the sensory piece is in relation to the self-injury. And we don't do it in a sense so much as the act while someone's self-injuring, but we're trying to figure out more at the individual level of what their sensory profile looks like in relation to, I'm going to use a couple technical terms, gain or loss. And in IDD, the dominant kind of narrative is always there's a loss of sensation or sensory. And I'm not talking primary, I'm talking like tactile and pain. So being the importer, we've imported a sensory testing protocol from psychophysics into our world and try to modify it to adapt the fact that people aren't going to tell us that they feel things. So we use a lot of video looking at facial expression, time locked to different sensory modalities, light touch, deep pressure, pinprick, so an acute noxious stimulus. We repeat a light touch that's 60 hertz, once every second for 60 seconds. Heat and cool. So those are dominant sensory modalities for touch and pain in your skin. So why we do that? We would do that because there's information with regard to those modalities, for the most part, of the kinds of transduction mechanisms that get up to the brain. People forget, so if I'm doing this, or I turn around and jab Courtney, besides being fired, that's one synapse away from the brain, right? And everybody wants to get to the brain, I get it, but in our work, we're out in the periphery of trying to figure out if we can do more careful sensory assessment of individuals with and without self-injury that are otherwise kind of the same gender, age, developmental level, can we learn something? So we're active in trying to pursue that because we think it might matter, that there's probably different sensory profiles related that you can characterize legitimately scientifically based on patterns of reactivity to those modalities that might matter for understanding the sensory properties. So that's where we are.
Can I respond to that?
Yeah, you can.
So with my daughter, I've talked to her about, okay, so this is a very scary behavior for other people and it's very dangerous to your skin. So I understand it's a release for you. What else can we do in replacement of that? So we talked a lot about different sensory things, and she has found that when she puts ice on her wrists, that gives her the same release sensation. So that's her replacement behavior for that. So we try to have like ice packs available for her at school and all those types of things. But she's also tried the rubber bands, things like that. But it doesn't provide the same feeling as ice does. And I don't know why that's connected for her, but that was the one that we came up with. But we went through that whole list, like soft, smelling things, like anything, but ice seems to work really well.
I mean, when I hear that, and it ties to some other comments made in general around this issue, is to think functionally. Think functionally. I heard functional assessment. We didn't really unpack what that means, but that's the basic premise. There's some variants, but you're trying to understand function. And you're going to understand function. If you can, you talk to the person. If you can't, then we're going to look for patterns and signs in the behavior itself in the individual, but also in the antecedents and consequences. And we're going to try to link those as functional units, but we usually have some implicit, so make it explicit hypothesis around those functional units. It might be communication, it could be health, it could be psychosocial like anxiety. So just taking an antecedent behavior consequence isn't antithetical to thinking about there's an underlying mood disorder, there's an underlying health issue. Behavior and biology work together, right? It's not either or. So it's trying to understand those functional units, functional communication, how to understand what they're expressing, and then understand the individual in terms of, is there a health issue? Is there a comorbid health issue? Is there a comorbid anxiety issue? Figure that out too at the same time. So think function. So I'm going to stop. I'm going to show you what I was going to, what else was there to ask. If you could assess, what would you do and why? If you could intervene, what would you recommend and why? Okay, last bit. For those of you interested, just to www.hollandbloorview.ca, this is up in Canada, it's a rehab hospital, /toolbox. This is a great site. It's a laundry list of a variety of pain checklists in different ways, shapes, and forms for slightly different reasons, acute, chronic, that have been used, tried, worked, developed specifically for individuals with intellectual and developmental disabilities. So hollandbloorview.ca, yay Canada, /toolbox. And I live here, so if anybody's more interested, not right now, but ever catching up and talking about the work our group's involved in pain, self-injury, or Rett syndrome, we do a lot of this. I saw someone at Gillette. We're down at Gillette a lot. We have people that are Gillette, so that are colleagues that we work with and our group's embedded. There is a Rett syndrome clinic that runs out of Gillette. We have a sensory research lab that we do a lot of the sensory testing I'm describing, a lot of videotape. We also have everybody, as you might guess, wired up so we can look at heart rate and heart rate variability and all that stuff, and we collect saliva to try to get the full picture in terms of as much biology as we can to understand behavior and vice versa. But anyways, I'm going to stop, but that's a good website if you're at all interested. Thank you. Thanks for the opportunity, Team Science back there. Have a good day, guys.